So welcome to This is Getting Old. I'm your host, Melissa B., PhD, and today we're going to be talking about more nursing in nursing homes. And I'm joined by this wonderful group of my friends and colleagues, all of which have very extensive backgrounds and histories in nursing home care and nursing. And I'm going to let them introduce themselves and then we'll get started. So Marie?
Hi everybody, I'm Marie Boltz. Thank you for inviting me, Melissa. It's great to be here. I'm a professor at Penn State University College of Nursing. I'm also a geriatric nurse practitioner and a nurse researcher, and my experience in nursing homes includes as a clinician, an administrator, a researcher, and also a consultant.
Okay. Charlene?
I'm Charlene Harrington. I'm a professor emerita at the University of California, San Francisco School of Nursing. And I've studied nursing homes for 35 years and looked at staffing, ownership, financing, legislation, and regulation. So.
Okay, Barbara?
Yeah, I'm Barbara Bowers, and I'm on the faculty professor at the School of Nursing at the University of Wisconsin-Madison, and I've spent over 30 years as a teacher, researcher, and clinician in long-term care settings. The thing that people are most interested in is I worked as a CNA for several years in a nursing home to put myself through undergrad, and then worked as a nurse in nursing homes, and something I'm passionate about.
Okay, Anne?
Well, hello, I'm Anne Koloneski. I'm a professor emerita of nursing at Penn State College of Nursing. And in my younger years, I worked in a nursing home. As a matter of fact, that got me through my graduate education. For the past 30 years, I've been a teacher and I've done research on non-pharmacological interventions for residents who have dementia in nursing homes. So, I'm happy to be here.
We're happy to have you. Chris?
Hi, my name is Christine Miller, and I'm a professor in the School of Nursing at the University of Minnesota and hold the long-term care professorship in nursing. And just like my colleagues, I've been involved in studying the nursing home care and nurses in nursing home care, particularly being interested in factors that are associated with quality, and even more specifically, nurse-related factors for quality in nursing homes.
Great. And Tara?
Hi, thank you, Melissa, for this opportunity. I'm Tara Cortes, and I'm the Executive Director of the Hartford Institute for Geriatric Nursing at New York University Rory Myers College of Nursing, and a professor of nursing in the college. My career has spanned many years in hospital and nursing administration, and most of my last 20 years have been very focused on the care of older adults, with a particular emphasis and interest in long-term care.
All right. Well, thank you, ladies. And I guess I've been also involved with nursing home care since 1996. So between all of us, we have probably a lot of years of experience. So, so since we've all been in the business for quite some time, Marie, maybe you can give us a little kind of snapshot about how nursing homes are different today than maybe they used to be.
Okay, thanks, Melissa. Like everybody else here, I've started out my career as a nursing assistant. So the resident that I typically took care of as a nursing assistant was somebody who needed some help, maybe a little bit, maybe moderate help with bathing, dressing, and grooming. And they no longer could live at home, so they came to the nursing home. So that traditional type nursing home resident still exists, but that person, as the population has aged, has become more frail, living to advanced age, and also living with dementia. So these are folks who are in their 80s, 90s, sometimes 100 plus, who have a lot of comorbidity and high rates of cognitive impairment, and sometimes serious mental illness overlaid on top of that. So as you can see, the care is very complex. A lot of folks think that nursing home care is stable and sort of unexciting and doesn't vary from day to day, but in fact, it's very complex in that residents with multiple comorbidities and conditions need a lot of really extensive assessment and care management. Because when they do become ill, often their symptoms are subtle and atypical and very hard to recognize. So they really need a very good clinical assessment and development of a plan. As I said, many of our nursing home residents live with serious mental illness. Some of them are struggling with substance use disorders. So that adds another layer of complexity. And then on top of that, many of our nursing homes are admitting residents directly from the nursing home who are requiring skilled or subacute care. So these are patients from the hospital who very much look like hospitalized patients in terms of their medical acuity. For example, they might need extensive wound care or infusions or very close medical assessment. So this combination of lots of comorbidity, often superimposed on chronic mental health challenges, requires nursing care that is very, very skilled and very much specialized to the care of older adults. So the combination of these in concert with trying to provide a home-like environment and honor preferences really can challenge nursing home staff.
Right. I remember even asking my students, you know, what is this term skilled nursing home? What does that mean?
Mm.
And, you know, so I'm going to do another podcast about the different levels of care within the whole long-term care trajectory. But a skilled nursing home means that the skills that we know to do, and, you know, that skill set is what's needed for a skilled nursing home compared to a rest home or assisted living. And then there are big differences between our skilled nursing homes and our hospitals and how they're treated. And that's actually how we all got together today, is, you know, based on COVID-19, looking at the differences in how hospitals are treated from skilled nursing homes. So maybe, Anne, maybe you can share some insights about how these two systems are different.
Okay. Well, as Marie pointed out, today nursing homes are where people who have very complex chronic conditions and functional limitations, where they live, in the hope that they can receive care that's going to give them a good quality of life and not just custodial care. But sadly, nursing homes and long-term care in general are not seen as an integral component of our healthcare system. This is unlike the acute care sector. This has come, I think, front center in the current pandemic crisis that we're living through. We're witnessing now the enormous gap in investment in not only our public health system, but in long-term care. And this historic lack in investment, I think, has been exacerbated as more nursing homes move to for-profit status, and also because of the reimbursement system that we have that's not adequate to support the types of care that people who live in nursing homes today, the care that they need. So what does this translate into? Well, it translates into fewer professional nurses, registered nurses, who are available to give direct care, and also a lack of investment in staff development overall. Many of the professional nurses who are in nursing homes are not involved in direct care. And when they are, they're not practicing to the full scope of their license. They may be involved in tasks like passing medications or administering treatments, rather than doing the type of work that only a professional nurse can do: the assessment, the care planning, the mentoring of staff to make sure that residents get the type of care that they need. There's also tremendous gap in nursing leadership in nursing homes. And again, I think it goes back to this lack of investment. Right now, many states don't require that the director of nursing have any more than a license an RN licensed to practice. Many directors of nursing have an associate degree, no certification, and this is very unlike what happens in acute care settings where nursing leadership typically has, graduate education along with certification. The lack of investment and the reimbursement structures that we're dealing with today also give us a lot of gaps in salary. Tremendous difference between what a nurse can make in a nursing home versus a hospital or medical center. And so all of this, I think, contributes to a very high rate of professional staff turnover, and this in turn contributes to a real inability to sustain any positive changes that may have been started. So I think there are some very general ways where you can see a tremendous difference in acute care versus long-term care.
Okay, so when we talk about having more nursing in nursing homes, maybe Charlene, you can talk to us about why do we need more nursing, or what is the issue with staffing in general before COVID and now with COVID?
Well, let me just start out by saying there have been many excellent research studies that have shown the strong relationship between having more nurses, especially registered nurses, and quality of care. And I'd like to go back to the 1980s when there were real quality of care problems, and I was on an Institute of Medicine committee that recommended a number of reforms for nursing homes that were implemented into law in 1987. But one of the major failures of that effort was that there was no recommendation for minimum staffing standards. And in 2010, there was more legislation that improved the quality of nursing home regulations. But again, there was no requirement for minimum staffing standards. And in 2016, the Obama administration increased the regulations for nursing homes. But again, minimum staffing standards were not included. And so as a result of that, before the pandemic, 75% of nursing homes in the United States did not have adequate RN staffing levels and did not have adequate total staffing levels. So this resulted in a number of nursing homes having very poor quality of care. And so when the virus hit, it wasn't a surprise that many nursing homes were not able to prevent the spread of the disease throughout the facilities. So we have just finished a new study in California looking at which nursing homes were the most likely to get the COVID-19 virus. And it was no surprise that we found that nursing homes that had low RN staffing and low total staffing and poor quality were the most likely to get the COVID virus. And we also looked at a minimum registered nurse staffing level, which has been recommended for over 20 years to be at least 0.75 RN hours per resident per day. Nursing homes that had under that level were twice as likely to get the COVID virus as nursing homes that had higher RN staffing and higher overall staffing standards. And what we see is that over 70% of nursing homes in the United States are for profit. These nursing homes are trying to make money for their owners and their shareholders, and many of them are big chains. And one of the ways they do that is by keeping the RN staffing levels low because they're the most expensive type of nurse, and their overall staffing low. And this is what has contributed to the persistent and chronic low staffing in nursing homes around the country. We also know that before the virus hit, 63% of all the nursing homes did not meet the infection control standards and were given deficiencies by the state surveyors. And again, that was primarily because it's directly related to the lack of registered nurse staffing in nursing homes who are essential for developing infection control plans and implementing those plans. So I think what we have learned since this has happened is that registered nurse staffing and total nurse staffing in nursing homes is essential. And those nursing homes that are rated on the Medicare Nursing Home Compare website as having low staffing are dangerous places to be. And so I really think we have to fight much harder with both our research and our advocacy work to try to get higher minimum standards set in nursing homes around the country so that we can handle things like infection outbreaks and improve the basic quality of care in nursing homes.
Yeah, my first job out of nursing school was as an infection control nurse in the nursing home. And now I don't see that position. And I was also the only baccalaureate prepared nurse in that building. And within 3 months, I was the director of nursing. So 23 years old, running a 125 bed facility, and had my license all of 3 months. So, you know, the other part I think for the public is just understanding the types, like collectively, the caregivers in a nursing home are called the nursing staff. But maybe Chris, you can kind of talk to us about, you know, the different roles of these caregivers and their education and training, just to help people understand who these people working in nursing homes are.
Yeah, I'd be happy to do that. And I think it's interesting, a commonality that we all have is we either have been a nursing assistant in a nursing home, as have I, and I've been a registered nurse, and I've been a director of nursing in a nursing home. So yeah, you're right. We kind of lump nursing staff all together. And in nursing homes, there's typically 3 different types of nursing staff. The nursing staff that there's the most of are nursing assistants, or sometimes they're called certified nursing assistants. And they actually just provide the day-to-day care. They take care of the residents. They help them with getting their meals, eating and bathing and dressing and walking. All of those important things that older people in nursing homes need and who are so vulnerable. But then there's another group of nurses, and they are licensed nurses. And there's 2 types of licensed nurses. One is called licensed practical or licensed vocational nurses, and the other is registered nurses. And you can't really tell the difference. It's usually the person that the public will think of as the nurse. The licensed nurse is the one who's giving out the pills and who's doing the treatments and who's maybe on the phone to the physician. That's usually what they will see the licensed nurse doing. So a licensed practical nurse is somebody who's had an education program either in a technical or community college, about a 9 month or 12-month program. And after they finish that program, they then become licensed to practice as a practical nurse. And every state has a scope of practice for a licensed practical nurse, what they can and cannot do. And then for registered nurses, there's 2 ways to become a registered nurse primarily in this country. One way is to do a 2-year associate degree program in a community college where they get an associate degree, or a 4-year university program where they get a baccalaureate degree in nursing. both educational paths lead to being licensed as a registered nurse. So what often happens in nursing homes, and it's been pointed out already that it's perceived, you know, registered nurses, we have fewer of them because they cost more money. The majority of the licensed nurses in nursing homes tend to be licensed practical nurses. Both licensed practical nurses and RNs, registered nurses, they can distribute medications, and they can do treatments, they can take doctor's orders. These are all these tasks that need to be done, and you have to have a licensed nurse to do those things. So that then results in this phenomenon that we've been noticing for years and years, and that's the interchangeability of RNs and LPNs. So if you need a licensed nurse to give out the medications on a particular shift, many nursing homes do not differentiate. If they happen to have a RN on the schedule for that particular shift, then the RN will do it. Or if it's an LPN, the LPN will do it. So what the big difference between an RN and an LPN is not only the educational difference, but it's what the RN can bring to meeting the needs of the people who live in nursing homes and are being cared for in nursing homes. And that's those professional nursing care needs that the residents have, which is really being able to have good assessment of the symptoms or how they might be presenting. And then the clinical reasoning that the registered nurse uses in taking that assessment data and coming to conclusions that lead to actions for what that resident needs. So because we have such fewer registered nurses in nursing homes, one of the consequences is that these professional nursing needs that the residents have go unmet. And the registered nurses are not being used to their full scope of practice. They're focused primarily on task. And so that then results in poor outcomes for our residents. Can result in delirium or dementia or incontinence or pressure ulcers. And those are all things that can be prevented with good nursing assessments and interventions. And then I'll just conclude with one other role of nurses in nursing homes, and that's the director of nursing. So every nursing home is required to have a director of nursing who has to be a registered nurse. There's no requirement in regards to the education level of that nurse. And this director of nursing is essentially 100% accountable for the nursing care that's given in that nursing home. So not only does this director of nursing need to have good clinical skills, because sometimes they're the only RN, but they also need to have good leadership and management skills. They need to understand human resources. They need to understand all the factors that are associated with recruitment and retention, and on and on. And most, associate degree programs that prepare somebody to be a registered nurse typically do not address that. And baccalaureate programs probably do their best to address that, but not quite to the extent for someone who would have that kind of responsibility and accountability in a nursing home. So we have lots of improvement that also needs to be made in terms of the role and qualifications of the director of nursing.
Yeah, so two things came to mind when you were talking. One is I remember my administrator at the time, we had a treatment nurse who was an LPN and I was the RN. And the administrator was frustrated that the LPN wouldn't create a plan of care for the LPN. And I was like, they can't. This is beyond her scope of practice. You need an RN to do that. And I was like, how is it possible that I'm having to explain, scope of practice and what these people can do? And I think it is this interchangeability, and people don't really understand nursing or scope of practice if you're not a nurse. And then the other thing you're bringing up is kind of the leadership and management piece that you need in addition to your generalist degree as an RN around budgets and, how do you advocate for all the things that your staff needs in order for the patients to get the residents to get the quality of care. So, so many things. So Tara, now in the middle of COVID-19, the Center for Medicare and Medicaid Services is going to create this commission for safety and quality in nursing homes. So maybe you can talk to us about what that is and what it's intended to do.
Sure, I'm happy to. The Coronavirus Commission for Safety and Quality is really meant to do a comprehensive assessment of the nursing home responses to COVID-19. It will then provide recommendations to CMS to help inform the COVID-19 response, what's going on now, what has gone on, but also to prepare for future epidemics in nursing homes. However, I don't think this is the be it and end all, and I really think more has to be done at the state level. I think each state needs its own task force, because at the end of the day, it was the state that was dictating the actions in the nursing homes during the height of COVID-19. I happen to live in New York City, the epicenter of the epidemic, of the pandemic, and we saw tremendous loss in nursing homes here. The additional regulations and punitive actions are not the answer, and that is what's been kind of fielded. Let's have more regulations on what nursing homes are doing, and we're going to, we will be looking at what they did during COVID-19. The real answer is nursing homes must have a planned program of infection control with adequate staff, adequate personal protective equipment, and adequate testing. Many of the nursing homes here in New York are preparing for this. They are doing this actively, and I've asked them, is this just a wish list, or is this an actual, you will do it? And the answer is we will do it because we have to do it. The belief is that this pandemic is not going to go away soon, and we will continue to have pandemics, is the belief, because of the more frequent interaction we have between wild animals and human beings. So they're planning on this as being kind of like an everyday occurrence, or you just get ready to have good infection control at all times. We also need smaller nursing homes. Congregate living has shown to be a real detriment to keeping people free from infection. You have 4 people in a room, one gets COVID-19, and all of a sudden 4 have COVID-19. Another issue has been the asymptomatic spread of COVID-19. We don't know who has it and who doesn't, and without adequate testing, we weren't able to see who had it. So these are all the issues that have gone into the nursing home actions and what needs to happen, but it cannot happen without an adequate payment system. It's mostly Medicaid is the provider of the financial support for nursing homes, and it really does not provide for much more than custodial care. As a country, we must make a serious investment in the systems that care for our older people. That means nursing homes need to be recognized and reimbursed as a vital part of the healthcare system and as equal partners in the healthcare system. Medicaid reform or Medicaid payment isn't really the answer. I mean, some things that are being talked about are specialized Medicare Advantage plans that build into them nursing home benefits. There's also talk, there has been talk for a number of years, but of course it hasn't moved anywhere, but what about a Medicare Part E, where people actually pay a little more for a premium and have long-term care insurance included in their Medicare benefit? This epidemic, this pandemic, is a disruptor. Now is the time that we can make change in nursing home care, in the way in which nursing homes are run, but primarily in the way in which they are reimbursed and paid for their services so that they can be equal partners at the table and also have the right staffing so they can give the right care at the right time.
Right. I think that the contrast between federal legislation and Medicare, Medicare only pays for the first 120 days after an acute event in long-term care or in a skilled nursing home, which most people don't understand. Then you have to go into a spin down type process and deplete your assets. And then once you have nothing, the state can pick up with Medicaid. But it's a completely different form of payment. So it is Medicare and Medicaid funded and private also. But CMS sets the rules and regulations, which they're dictated by Congress. So sometimes it does take an act of Congress to get some change through nursing homes. So speaking of that, Barbara, maybe you can talk to us about some current legislation in light of COVID-19 and some positive things that may come from that, and then what do we need to continue, and what really should be pushed for after post-COVID nursing?
Right. Great question. So I think the current legislation that's pending is really about, it's a very short-term fix. It's about during the pandemic and doesn't really go beyond that. And so I think the most important things in there, in that list of items in the legislation, probably the two most important are 24-hour nursing coverage, which most people are shocked to find out we don't have that right now, of RN coverage. Right now, RNs are required to be in the building 8 hours a day. It's often the director of nursing, and as you described, in many cases, someone who hasn't graduated all that long ago is trying to run the place, manage things, and they are the 8 hours of supposed nursing care that's being provided, when in fact it's not really about direct care in most instances. The other thing that's in that legislation is an infection control nurse or person, not necessarily a nurse, in the building, that each facility have someone who has that particular role. I certainly can't argue with either of those. I think one of the problems is that it's limited to the pandemic. If the pandemic is limited at all, we don't know what's going to happen. But those are issues that have been problematic for a very long time. The infection control, which someone has already talked about, but I think also the level of nursing of RN staff, but also the training. There's very little in there about training or education. And I just wanted to say a little bit about that because I think it's really important. First of all, I don't think there is a very general awareness of the level of skill that's required to take care of this population. It is a lot of cognitive skills, decision-making, that are really important in order to keep people healthy, keep older people out of the hospital, which is the worst place for them to be. All sorts of bad things happen when you send someone, an older adult who's frail with multiple comorbidities, ends up in the hospital. It's a problem. There is not a sufficient knowledge base in the nurses in long-term care across the board. I would say nursing staff, not just nurses, but the CNAs who are often included in the nursing staff. I think there's a general perception that either there's not much to know, since this is just custodial care, or else, as I've heard repeatedly from the nurses and directors of nursing in long-term care settings, everybody knows what they're supposed to know. The knowledge base is sound and sufficient. And I think we don't have a lot of data on this, unfortunately, but the data that we do have would suggest that that's in fact not the case. There's a pretty significant knowledge gap that exists. And so we need to have a good way for people to learn what they need to know. Right now, there's very little. There's very little ongoing education. Most of it is internal. It's using the fire extinguisher and using new products that are coming online and responding to deficiencies in the survey. There's a lot more to care than those few things, and that would require nurses and CNAs to be able to leave the building and go to educational programs that are offered outside. I have talked to many nursing home nurses who say they would love to. They would love to continue their education, supplement it, learn more about all kinds of things, but they can't because there's not enough staffing. They're never able to leave. This is also the case with direct care workers, the CNAs. We put on a workshop recently, toured the state of Wisconsin and took a group of educators with us, invited CNAs and personal care workers to come and attend. And I can't tell you how many CNAs said to us, I've been a CNA for 15, 18, 22 years, I think was the longest, and I've never been to a workshop before. I've never been to an educational program, only things in my facility about how to use equipment, things like that. So we have a long way to go. This is a complicated group of patients, residents. They need skilled care. And I think one of the most important things that's not sufficient either in the legislation or recognized anywhere else is that we have a long way to go in terms of upskilling and providing the educational support for people who work there.
Yeah, and I've often said, I mean, people that work in long-term care and in geriatrics, we're not there for the money.
Right.
You know, we're there because we actually care and they do want to do a good job. And I think that's one of the things that's frustrated me the most with the media coverage is that they would say, you know, and then the staff didn't show up. And,
right.
You know, there's been plenty of coverage about, you know, no PPEs, you know, not having enough equipment to be safe. the staff aren't just showing up because they don't feel like going to work. It needs to be a safe environment for them, because it is truly their family.
For once, there are some positive stories. There have been a couple of stories that are really nice about the compassion, the caring of staff in nursing homes, and how hard they're working to connect the residents with families who are not able to get into the buildings. I've talked to reporters about, couldn't you do a positive story about the things that go on in nursing homes? There are plenty of positive things to say. Nobody seems to be interested in doing that.
Yeah. Well, that's why we're doing this today. And my grandmother is in a nursing home in rural North Carolina, and the staff do FaceTime, with my grandmother. And at first it was, it was a little bit hard for my grandmother to understand what was going on, because she does have some mild, dementia. And now she just kind of holds court with her FaceTime. And then when she gets tired of talking, my mom says, she goes, okay, she needs her device back. So she's done, but nobody actually asked my grandmother to stop. She's figured out yeah, I'm kind of done. So they need their phone back. So any final thoughts or other things you want to tie together before we conclude our time here together?
Well,
I think it's, oh, go ahead, Charlene.
I just wanted to add one important point about the infection preventionist. Right now, that many nursing homes, to save money, have assigned that to an LVN. And they really don't have the training or the expertise to be an infection preventionist. And I think that any legislation needs to strongly encourage that. It should be a registered nurse or with special training in infection control, or a physician.
Yeah, the same thing happens, I think, with educational programs. Staff development people in nursing homes are often someone who can no longer do work on the floor, and so they're assigned education. And I think as a group of educators, we understand there actually are some skills involved. There's effective education and there's not so effective. So that's another place where I think we need to recognize that there are skills required.
Yeah.
And I also think we need to educate the public. I think a lot of people, first of all, don't even understand or realize that their Medicare doesn't pay for long-term care, and they're surprised, just as they are surprised that dental care, eye care, hearing aids are not paid for by Medicare. So I think we need to educate the public on the value of long-term care so that they too can be advocates for us and for their older family members, their siblings, their mothers, fathers, aunts, and uncles, so that the appropriate quality care can be given. But I think we need help from everyone.
Yeah, Sarah, this is a really important point, because the only people who really understand what's happening in long-term care are people who are actually in the system. And they're always shocked when they get in there to find out about all the things that aren't available. And they're in no position to be doing any advocating. They've got enough on their hands. And so somehow we need to create a much wider coalition of people who see what's going on, care about what's going on, and can do something about it.
Mm-hmm. I also think that we need to be conscious of language and how language influences perceptions. I mean, we use the term skilled to speak about a resident who's post-acute, who requires rehab or requires some type of complex nursing treatment. That person, in my opinion, requires no higher a level of nursing competence than the person that we refer to as custodial, which I think we need to get rid of that term, because it really undermines the work of nurses and nursing assistants. So I think that that's really an important thing to consider. A resident who is medically stable and has chronic comorbidities and has dementia and has anxiety and fear requires, in my estimation, as much competence and as much skill as somebody who's requiring total parenteral nutrition.
I think that's a good point, and I think that we do need, it's part of the public education, because most people think about nursing homes as providing custodial care, and they don't have any idea about the complexity of the patients or the residents that are now living in these homes, and how difficult it can be without adequate support.
And I'd like to pick up on a point that Barbara made about staff development, particularly for the managers and directors of nursing. Maria and I, this past year, were involved in a leadership program with nurse managers at VA CLCs across the country. And even though these people, many of them they all had bachelor's degrees, many of them had master's degrees, and I think there was a real hunger for more leadership as well as geriatric nursing content. So they realized they were in their position for at least a year, and they realized what they did not know. So I would, strongly support any type of continuing education and leadership training for registered nurses.
I'd like to make a point about the payment system that Tara brought up. I think Medicare is paying nursing homes well. But the problem is they have no requirements for what the money is used for. So once a nursing home gets that payment rate, they do not have to spend it on the nursing or in investing in the care. They can take it out in profits and administrative costs and all kinds of related things, lease arrangements that don't contribute to the care. So I'd like to see a reform of the payment system so that the money that is allocated goes for the direct care and services with limits on the profit making and the administrative costs. Because right now there's no incentive for for-profit nursing homes to invest in their staff. They don't really care if they have a stable staff and a well-educated staff, because they can bring new people in at the lowest payment rates, and they can save money by having high turnover. And so the improvements need to directly be tied to changing the reimbursement system.
Mm-hmm. Right.
I guess I would just say we need to put nursing in nursing homes.
Yes.
Very well said. And on that note, I want to thank each of you for being here with me today to talk about getting more nursing in nursing homes. And thank you very much. Thank you for joining me today for This Is Getting Old. If you'd like to know more, you can subscribe to my YouTube channel. And if you have any questions or a related topic you'd like to hear from me about, just let me know. Thanks.